sad. I feel like we have to end this kind of conversation engaging. But nonetheless, this topic of the session today is unsettling consent, considering the phenomenology of shame in clinical encounters. So we have two brilliant and amazing speakers here who most of it we all know. But for those of you who do not know, Dolezal is an associate professor in philosophy and medical humanities at the University of Exeter. She is an author of many key articles on books on shame in clinical encounters, phenomenology, and feminism. Lyons is a pediatric anaesthesiologist at Children's Health Ireland, lecturer in medical ethics and law at Trinity College Dublin, and Director of Patient Safety at the College of Anaesthesiologists of Ireland. He works on intersection of emotional and psychological aspects of clinical practice, and of course, interested in also law and regulation. So one of the key works, if you have not read about with both of them, is on health-related shame and affective determinant of health, which I would strongly suggest it's a quite good article. And so over to you, Barry, today, and for Luna.
Thanks. I think that was the best bit of our talk. We've been talked up. So what we're going to try and do is sort of seamlessly shift from one speaker to the other as we sort of talk about areas that I suppose we have some expertise in. And our topic is that of informed consent, which is, I suppose, a small and private clinical area, but a really commonly repeated intervention. And it is, I suppose, to misappropriate the words of Leonard Cohen, a small area where the light often doesn't get in and shame can remain hidden. So the way we're going to proceed is I'm going to talk a little bit about I suppose, the technical legal aspects of informed consent, really with the purpose of sort of identifying why emotion is not part of the informed consent process, why it is excluded in many instances, and then talk a little bit about the importance or the relevance of emotion in general in the psychological literature to decision making. And then Luna will bring a phenomenological lens to an area where there really isn't a lens at all, to talk about the first person experience in the informed consent process. And then we'll discuss two particular areas where we think shame is especially relevant, cosmetic surgery and I suppose diminished healthcare or health literacy. And then we'll have some tentative conclusions. We started talking about this 2 years ago for this conference. Oh, sorry. Can you hear me now? Apologies. I have to sort of root myself. I normally walk up and down all the time when I'm talking, and I'm finding this really constraining. So if I walk away again, just shout at me. Okay, I can't remember what I was going to say there. So informed consent or consent has an origin story in medical law, and it dates back over 100 years to the unfortunate case of a young woman called Mary Schlorndorf. And she presented to a hospital in New York complaining of abdominal pain. And when examined, the doctors found a mass. And she agreed to an examination under anesthesia, but insisted that there should be no operation while she was asleep. So she duly was anesthetized and the doctors operated and removed a fibroma. Unfortunately for Ms. Schlorndorf, the post-operative recovery path was not smooth, and she developed gangrene in her left hand and ended up having several fingers amputated and lost the function in her left hand. So it's unsurprising to us, I suppose, in 21st century Europe that she would litigate as a consequence of this, but this was a significant event in 1914 in New York. She lost her case despite the sort of obviousness of why she should win on a technical legal point. But the case is remembered in the literature for the canonical statement of Justice Benjamin Cardozo, which I suppose for the first time articulates the rights of individuals to bodily integrity and to make their own choices as to what shall be done with their body. Over the next 100 years or so, until 2015, we've had a successive, I suppose, incremental build on that due to cases of litigation. And so we now have a series of standard rules around informed consent that are certainly applicable in all common law countries and are enforced and enshrined through European Court of Human Rights standards. So we know that consent is essential in almost all instances except for emergencies before a patient has an intervention or a treatment. We know that patients need to be informed in very broad or even specific ways about certain things, about the choices that they have, about the risks that they might undertake, about the benefits of particular procedures, and about the alternatives that they might get to choose from. And so the title or the sort of prefix of informed often goes with consent, and that's how we describe it now. We know that patients must have capacity, that they must have the competence to take particular decisions. And we know that they should be free from undue influence or coercion. And so we have this standard set of rules that are routinely applied. In cases where we're not quite sure about whether the patient has the competence or not, we have a second set of rules. So there are two basic questions that are asked, and this comes from the Code of Practice from the Mental Capacity Act in the UK. So does the person have an impairment or disturbance of mind or brain? And if they do, does that impairment or disturbance mean that they are unable to make a specific decision at a specific time? And the test, the standard legal test, is applied certainly in the jurisdictions of the UK and Ireland. And it's about if the person is given sufficient amount of information or the right amount of information. Can they take that information in? Do they understand it? Can they reason with it? And can they communicate a decision on the basis of that information? So these are the standards that sort of enshrine consent as it's standardly practiced within medical care. There are critiques of it because it's almost an exclusively cognitive process and focused on procedural matters. So it is a really limited engagement in a particular way. And the standard patient, once identified or is presumed to have a capacity or once identified that they have in cases of doubt, is viewed very much by the law as sort of a homo economicus, this rational, self-interested individual who is capable of internalizing large amounts of complex information, of reasoning with it in a logical way, and of coming up with a response to the choices that they have. So we have this cognitive procedural model of consent. And that's the sort of legal model. And it's a kind of an onerous model. And these are two, Fitzpatrick and Montgomery are two separate cases from two separate jurisdictions, but they talk about consent in a particular way. So doctors must provide clear explanations and clear informations, no matter how onerous that is in terms of time or effort or inclination, in every single case. In Montgomery, which is a UK case, which was around peripartum injury, they go a little bit further and they say doctors must answer questions that patients don't even ask. So they should understand where the gaps lie within that communication process. And out of this sort of cognitive process, we understand consent as having two purposes. One is to give effect to the autonomy of the patient, for the patient to have all the information and to make their own choices. But the second, and arguably more prevalent purpose in clinical practice, is protection. So a doctor who provides all the information about risks, benefits, alternatives to the patient and then performs the intervention competently is protected in the event of the patient being unhappy and there being a complaint or there being litigation. So they will have gone through the correct process. And because this process is particularly onerous, is particularly time requiring of time, and because of the demands for efficiency within the service, there really is no time or space in this engagement for anything that might be regarded as extraneous. And in this instance, emotion might be regarded as an extraneous element. I suppose the third reason why doctors might embrace this model is that the medical regulator in most jurisdictions also embrace this model, and in their code of practice, this is the model that is passed out as being the correct model to employ. Now, we know that this makes little sense in the real world of humans, and Mary Simmerling talks about living organ donation as a kind of a disruptive model to this standard process. And she talks about, imagine that you're a parent and your child is in desperate need of a kidney and that you are a match for your child. So you can donate your kidney to your child. Would you do it? And the answer is almost always yes. Yes, because of emotional ties. Yes, because of familial obligations. And that yes precedes the information. It's disruptive of the standard information, reasoning, decision process. So emotion enters into this process and the medical practitioners don't know what to do about it. How can you, it's portrayed as an irrational decision. You haven't had the information. How can you possibly make a correct decision? And so early work by Fellner talks about what happens in that kinds of a situation. The doctors delay the procedure. They force the information on the parents repeatedly. You have to hear this, you have to hear this, you cannot make a decision, you have to hear this. And they have to defend their choice throughout that process. And Fellner and Marshall at the end go, what are we doing this for? Because in their study, not a single parent changed their mind, which is unsurprising. So our ideas around consent are derived from some form of Millian view of autonomy. And really what we defend in law, in the consent process, is the right to be left alone, the right for the state or other agents not to interfere in our choices. And it's a particularly bare version of how we get to make our choices in real world situations. And according to Mary Donnelly, who's a health lawyer who talks a lot about capacity and a lot about mental health, this model completely fails people who are vulnerable because of social, cultural, or economic disadvantage. And she talks about instances in mental health care where patients choose interventions in fear of them being compelled to comply with them through a legal process, that the stigma of legal compulsion is worse than the intervention. So you don't have to have any of those disadvantages. We can understand that people who are suffering from serious illness and the sort of tumult and stress that serious illness brings might also be particularly vulnerable in this decision-making process. What Virginia Woolf describes as the uprooting of ancient oaks that are within us. And Mary Donnelly again cites Virginia Woolf to sort of articulate this view that, as opposed to literature, which Virginia Woolf was talking about, the law takes this perspective that the decision-making process in consent is a purely cognitive process, that is exclusive of emotion. And it doesn't deliberately exclude emotion, it's just silent on the subject and leaves no space for it to happen. And we know that emotion is important within decision-making processes. So I'm not going to do particular justice to the psychological literature on how specific emotions impact upon standard decision-making processes. And I'm grateful to a number of authors who've managed to consolidate a large amount of literature in a couple of short papers. That was very helpful. So according to Lerner, emotions constitute potent, pervasive, sometimes harmful, and sometimes beneficial drivers of decision-making processes. We choose often in a way that is impacted upon by our emotional state at the time. And Ferrer categorized the research in a way that she describes as arbitrary but helpful. So our emotions impact upon us in a way. So sometimes the emotion can be integral or normatively relevant to the decision that's in hand. So for example, I might suddenly have a fear, or I might have a fear for my health because I smoke. I might think about that, and that fear might enjoin me to go and to quit smoking. So the fear is relevant to the choice that I'm going to make. The emotion might be incidental, and we'll talk a little bit about that. And she subdivides them then into emotions that are current and emotions that are anticipated. So she said that emotions that are negatively valenced are particularly likely to influence health-related judgments and decisions because they provide important information to us. And so this emotion-induced sense of vulnerability can motivate risk-reducing behaviors in situations where we feel that we have control over those choices. So we can have, as I said, a fear of what smoking will do to us that will allow us to quit smoking. There's been some work done on disgust being attached to particular foods, which has helped people be motivated to choose a healthier diet. But they can work in the opposite way as well. They can act as an impediment to what we might call responsible decision-making about health in situations where we feel we have low control. And so there are situations, some work that indicates that people who feel disgust at the thoughts of having a colonoscopy and what that might entail are much less likely to attend for health screening than people who do not have that particular emotion attached to that particular process. The second thing Ferrer talks about is what she calls current incidental emotion. And those are emotions that are not attached to the decision. They are in a way free floating. They're carried over from other experiences. So we may feel sad because our grown-up child has emigrated to Australia and we feel a loss because of that. But that sadness pervades and can impact upon other specific decisions that are completely unrelated to the source of the sadness. And when you look at this carryover effect, you end up with a really complex response pattern that is related to a whole variety of things, the specific emotions, the specific context, but also things like race and gender, who view these emotions in different ways. The specific emotions that have been studied most are those of fear, anger, sadness, and disgust. And what you can see from the data is the complexity of both emotions and real life situations that make these things utterly unpredictable. They are personalized and individual decisions. What there is in all of this is little mention of shame. In fact, no mention of shame whatsoever. And there's very little data on the role of shame in explicit health-related decision-making processes. And I suppose given our perspective, this seems like a strange gap in the literature.
So I'm going to move on to talk about shame. So as Barry and I have written about previously, shame has been a frequently under-recognized and under-acknowledged emotion in clinical contexts, particularly in clinical encounters. And Davidoff in 2002 described shame as the elephant in the room in medicine or in clinical encounters, puzzling over why shame is still reluctantly broached as a research topic when there is evidence that shame is a powerful force that has clear clinical implications or impacts. And even almost 2 decades on, this is still the case. And there remains very little evidence about the impact that experiences of shame from patients and clinicians, how those might impact on how a clinical encounter unfolds. In Aaron Lazar's seminal article, which someone else quoted from in one of the recent talks, he talks about how shame is undoubtedly a common experience for patients. This is a 1987 article, Shame and Humiliation in the Medical Encounter, where, as I've put up his quote, patients may experience physical or psychological limitations as defects, inadequacies, or shortcomings. Treatments and their side effects may be potential sources of further shame and humiliation. And he gives examples: mastectomies, the loss of hair, and impotence. Understanding the phenomenology of shame, or how shame is experienced in healthcare settings, can reveal many dynamics, power relations, and affective forces that otherwise might remain hidden or subterranean. Shame about the body and its vulnerabilities is routine in healthcare contexts, and the body, especially as Lazar points out, when it is ill or fails us, is a powerful source inside of shame. So body shame, as we've discussed previously, is routine in medicine, where patients may be self-conscious, embarrassed, or feel shame about the physical body and its supposed failings or deviations from norms of health in terms of appearance or function. And in medical contexts, anxieties about bodily functions are linked to all sorts of things like aging, as we've seen, sexually transmitted infections, bowel movements, excess weight, loss of bodily control, stigmatized conditions like infectious illness, infectious disease. And beyond the inherent possibility for patients to feel shame about their bodies or physical conditions in medical situations, clinical encounters themselves can be shame-producing, and some argue are inherently shame-producing. So Salter and Hall argue that professional practice, like medicine and social care, are frequently vectors of shame, humiliation, and inequality. And that shame is very easily exacerbated and incited in the context of seeking help from professionals, especially healthcare professionals. These interactions often involve unequal power relations, a fear of being judged, the scrutiny and exposure of one's potentially shameful or embarrassing lifestyle choices, current or past circumstances, coping behaviors, body illnesses, mental health status, along with other vulnerabilities. And then exposing one's physical body and being subject to physical exams, especially when the body is put into strange positions or sexual organs are examined, can feel inherently shaming, embarrassing, or humiliating. And of course, if one's already experiencing high levels of shame anxiety because of living with body shame or a stigma, as Phil discussed so eloquently in his paper about HIV, living with HIV, then healthcare encounters where a shameful exposure can feel inevitable or can be strongly anticipated, these encounters may begin to feel particularly threatening to one's sense of psychological safety, regardless of the attitude or intentions of the healthcare professional one encounters. So it should be noted that while shame in healthcare contexts is often clearly health-related insofar as it arises from the body or illness, it should also be acknowledged that shame not related to the body may be a potent force in healthcare contexts and hence health relevant. So shame related to things like low literacy levels, poverty, trauma, class, one's social position, or other social dynamics or personal circumstances may be a powerful factor in how an individual interacts with healthcare professionals and other services. And in the context of seeking healthcare, it has been demonstrated that shame is a potent treatment barrier. And there is evidence, and it's a growing body of evidence, that demonstrates that shame is a potent force in clinical contexts and has strong effects when considering decision-making behavior. So the necessity, to use Bernard Williams' phrase, which Bonnie Mann takes up, to avoid shame or shameful exposure, can shape how individuals behave and interact within healthcare settings. So as Barry and I have written in our health-related shame article, we did a review of the literature about the very limited literature about how shame interacts with how people engage with in clinical settings. And there's some evidence that people may avoid seeking help in the first place, may regularly miss appointments, may avoid disclosing honest details about symptoms, their lifestyle or circumstances, may fail to follow through with treatments, may conceal diagnoses and coping behaviors from friends and family and professional. But interestingly, there is no evidence looking specifically at how shame and the necessity to avoid shame might affect or interfere with processes of informed consent. So despite shame's ubiquity and its obvious impact in encounters with health professionals, there is, so despite all of this shame's ubiquity and obvious impact in encounters with health professionals, there's evidence that addressing or acknowledging shame is routinely avoided in clinical and therapeutic encounters, as practitioners themselves are reluctant to acknowledge shame or address shame experiences, or may just simply not be trained or equipped to feel comfortable doing so. Because these experiences, bringing up shame or bringing up embarrassment it's kind of infectious. It may itself lead to further shame and embarrassment, and if not done sensitively and humanely, could actually cause more harm than good. So shame is kind of endured as this elephant in the room in clinical contexts. Despite this evidence that it has strong effects when considering decision-making behavior, and to think about how avoiding shame, or this necessity to avoid shame and shameful exposure, can shape how individuals behave and interact within healthcare environments. So to think this through, we kind of landed on two examples to think about how shame might affect the consent process. And the first is thinking about situations of decreased health literacy, which I'll speak about briefly first. And the second is thinking about body shame related to cosmetic surgery, which is something I've thought about before. So notwithstanding our critique of the procedural essence of the consent process that Barry outlined, the provision of sufficient information about the proposed procedure is obviously of immense importance. And the purpose of this exchange is to reduce the power imbalance between the clinician and patient, to kind of equip the patient with the information they need to take control of the situation. However, for this to be given maximal effect, the information, which is either verbal or written, must be provided in a manner that is comprehensible to the patient. They must understand it. And for patients with diminished capacity, legislation in some countries insists that doctors go to extraordinary lengths to ensure individuals understand given information. However, despite this need seeming obvious, it is unlikely that patients without a, quote, disease of mind or brain will be afforded the same consideration. In general, there is an assumption that patients who are so-called normal or are capable of internalizing and reasoning with standardly provided medical information. But of course, this presumption is problematic. The relevance of achievement in reading, writing, and communication skills is not simply that it has educational value. Rather, what is more important is that such proficiency enables us, what such proficiency enables us to do. And a standard characterization of literacy competence has been set out as follows. So first, there's basic and functional literacy. Second, communicative, interactive literacy. And then thirdly, critical literacy. And this classification indicates that the different levels of literacy progressively allows for the greater exercise of autonomy. So critical literacy giving one greater autonomy in their capacity to understand and reflect on information. So progression to the highest level of literacy is critical to personal empowerment. And conversely, lack of adequate literacy represents an important barrier to receiving high quality care. So according to the Institute of Medicine, individuals with these with low literacy are likely to have substantial problems obtaining, processing, and understanding basic information and services needed to make appropriate health decisions. And there is overwhelming evidence that limited literacy is a formidable risk factor for poor health outcomes. So unfortunately, diminished health literacy is a common problem amongst a predominantly in African-American community in the US. Parrick et al. Evaluated that over 40% had inadequate or marginal functional health literacy. And there was a correlation between lower literacy and male gender, older age, and lower educational attainment. However, low literacy is frequently not disclosed. So many patients in this study had never divulged their illiteracy even to their spouse or other family members. And many of these admitted to feeling shame in response to their perceived inadequacy and therefore kept it hidden. So consequently, patients with low functional health literacy often do not bring anyone with them to health appointments. They don't, nor do they ask for help. In fact, they pretend to themselves or others that they understand health documents and conversations, potentially jeopardizing their treatment and well-being. And so this is all part of the necessity to avoid this shameful exposure. Some patients may even avoid care altogether because of embarrassment about their illiteracy. And the shame felt about literacy difficulties is such that they cannot even admit to hiding it. And so in response to this, there's been debate over whether literacy tests should be used routinely in clinical practice to screen patients for potential problems. And the benefits of literacy screening might seem apparent. However, identifying patients as having limited literacy may, of course, result in adverse consequences, such as feelings of stigmatization, further shaming, and potentially more avoidance of health services to avoid more shameful exposure. Empirical data has indicated that a significant number of patients have reported that they would feel ashamed if medical staff knew of their limited literacy. And so in this instance, shame compounds the barriers to health already wrought by limited literacy. And while it's difficult to assess the impact of low health literacy in relation to informed consent, it is an interesting question that we've been thinking about, to think about how shame and negative self-conscious feelings related to literacy would motivate decision makings in ways that might have been otherwise. Another area where this seems obviously significant is cosmetic surgery, where the relationship between shame and informed consent might be very important. And while there have been many feminist critiques of aesthetic, I'm thinking about elective aesthetic surgery practices, it wasn't until the publication of Jane Megan Northup, who's an Australian nurse from Tasmania, her study from 2013, reflecting on cosmetic surgery, body image shame, and narcissism. It wasn't until this study was published that there had been any explicit analysis of cosmetic surgery in respect to the experience of body shame, which is kind of astonishing, nor much consideration about how women's experiences of shame may be compounded in clinical encounters where there's often a strong discrepancy in power relations between usually male surgeons and usually female patients. The more recent studies in the last decade have explored links between shame, body image, and cosmetic surgery, particularly as related to things like social media use, body dysmorphic disorder or BDD, and experiences of trauma. However, there remains little evidence about how shame impacts on informed consent for these procedures. And despite the obvious focus on the physical body in cosmetic surgery practices, and the promise of ameliorating physical flaws, a common justification by doctors and by the medical establishment for the need for elective aesthetic surgery, which is not medically necessary, is not about the physical body, but instead related to the alleviation of psychological distress, so psychological cure, as it's sometimes called. So the idea is that cosmetic surgery will alleviate anxiety and suffering that an individual experiences because of the perceived flaws they have in their body image and the threats to one's social standing that those flaws might incur. And while shame is rarely acknowledged in the literature on psychological distress related to body image dissatisfaction, as Northup makes clear in her analysis, cosmetic surgery's so-called psychological cure is intimately connected to shame and shame dynamics. She notes, and I think this quote is up on the slide, she says, participants, or kind of contradictory or paradoxically, participants only occasionally use the term shame to describe how they felt about themselves, and rarely spoke of feeling ashamed of their appearance. And despite remaining largely unarticulated by patients and doctors in her interviews, Northup found that shame about the body to be the structure driving not only women's decisions. Sorry, my paper just disappeared. Not only driving women's decisions about surgery, but the entire transformative arc in which cosmetic surgery is located. And she writes that some of the women that she interviewed who undertook cosmetic surgery described their engagement with cosmetic surgery as a preemptive act of impression management so kind of a type of shame avoidance undertaken to avert a loss in status or to secure confidence in others, or confidence of others. So if body shame is driving women's decisions to undergo aesthetic cosmetic surgery, and then this becomes relevant for considering the effectiveness of informed consent for these procedures. A shame will clearly be a strong driver of decision making. And it is well documented that avoiding or eliminating shame can lead individuals to act against their own best interests, or even engage in actions or behaviors that will harm the self. Shame can feel like such a potent threat to one's self, sense of self, one's identity, and one's social bonds, that it creates this necessity, and individuals will go to great lengths to avoid or eliminate it. So the women who are most driven by a chronic appearance-related body shame are kind of the ideal candidates for cosmetic surgery. These women will likely easily consent to procedures which promise to eliminate or alleviate their shame-related distress. However, when these preoccupations, a desire slip beyond an allegedly normal preoccupation with appearance into the realm of pathology, these women are eliminated as candidates for surgery and encouraged to seek psychological or psychiatric assistance. So surgeons are regularly advised not to operate on those who suffer from mental health issues like BDD or body dysmorphic disorder, or other disorders which are characterized by chronic body shame and dissatisfaction with appearance or body image. So the idea is that no amount of surgery is going to alleviate the distress. These individuals are unlikely to be satisfied with the results of their surgeries, nor to experience any relief from their psychological suffering, and they're most likely to become litigious. However, as the feminist scholar Cressida Hayes has noted, while rejecting those with BDD as potential candidates for surgery because of these concerns about litigation, doctors simultaneously encourage BDD-like behavior in their healthy and suitable patients who turn to surgery as a result of dissatisfaction with minor and sometimes even imperceptible flaws in their appearance. So Hayes remarks, the cosmetic surgery industry contributes to the production of a subjectivity that it then pathologizes if enacted too convincingly. And she notes that this, of course, is tremendously paradoxical. So with psychopathologies like BDD setting a threshold for where informed consent might break down, there's much to interrogate with respect to normal experiences or non-pathological experiences of shame within the realm of elective cosmetic surgery. And interestingly, in the literature, there's almost no mention of these concerns. So I'll pass it over to Barry to conclude.
Okay. So to conclude, I want to finish with a story, I suppose, that resonates with what Jane was talking about this morning. Because the encounter between the doctor and the patient for informed consent, or encounters because it's viewed as a process, is of fundamental importance in terms of how it's conducted. So if we imagine we have an 80-year-old man who has cancer of the prostate, and he needs some form of intervention to alleviate him of his malignancy. So there's an intervention that gives the best chance of the best outcome. But that intervention also carries the highest incidence of post-surgical impotence. So the doctor might not discuss this with the patient. He might make presumptions about the sex life of octogenarians. He might be embarrassed to talk about it. And so the choices on offer may be framed in a particular way in terms of therapeutic outcome rather than necessarily personally valued outcome. The patient might end up being ignorant of these possibilities until after the event. The patient themselves might feel embarrassed or shamed to discuss sexual function with a much younger doctor. And so what we have is a situation where the patient really hasn't had the true opportunity to balance the benefits of particular interventions against their personal values, what they value most. Do they want cure, or would they rather some form of retained virility? And these things might be of no importance to the patient, or they might be of particular importance to the patient, but there's no space because of shame and embarrassment and presumption within that environment for these events or possibilities to be discussed. So shame brings various components with them that are listed up there. And they are all in a way related or correlated with submissive behavior, which we frequently see in the clinical environment. The problem with that is that that submission reduces the opportunity the patient has for self-determination. And afterwards, if they are unhappy with outcomes, and I think that this is a particular motivator in cosmetic surgery, because cosmetic surgeons never inquire about shame as a motivator for cosmetic surgery. If you do not alleviate the shame, then the person, regardless of the cosmetic outcome, will continue to feel aggrieved. And so you end up with anger at others that may be mediated through complaint or litigation. So the question is, how do we change this situation? And we can talk about bringing empathy, bringing a sensitivity to emotion, a shame sensitivity to the clinical encounter. But the consent process is so rigorously defined and created within the current healthcare environment that that kind of simple change would actually require a considerable rupture in the sort of fabric of medical practice. It's not, it would in actual fact give effect to what consent is supposed to be about, which is supposed to be about choices about ourselves, but what we have is a legal framework that makes it about something different. So that's us. So thank you very much for your attention at this sort of late stage.
Thank you so much, Barry and Luna, for sharing with us the social embedments of consent process or the decision-making process in itself. So we are open for the questions. Please raise your hands, and meanwhile, we'll just check on this.
We've answered all the questions.
So here, Alan Wilson has asked the question here, saying on the idea that the presence of shame preserves consent for others and for one's own dignity. I wonder whether you think experiencing shame specifically is necessary for this, or just one way of preserving or expressing such concern.
Your question does have
Okay, sorry. So it looks like we have a long Okay, so here we have a chat from Catherine. The question: the existence of body shame as motivating a desire for surgery does not clearly interrupt the informed consent model.
Thanks, Kathleen. And nice to see you're online. I think the idea is that excessive body shame, so the necessity to avoid shame and shameful exposure may lead one to make decisions that otherwise wouldn't maybe be made in one's own best interest. So I mean, there is evidence that people will do things that are irrational, illogical, against their own best interests, against the best interests of their loved ones, to avoid shame and shameful exposure. And I think that this was certainly what came up in Northrop's study and some other small studies that have looked at the impact of shame that motivate women to seek out surgery, and that ultimately this often comes at great personal expense or may even harm the self. So the idea being that they're more likely to consent. I think that this is the idea of the kind of affective force that's present for them in the clinical encounter, but which remains unaddressed, and there's no space for it in the consent process. may lead to a kind of accelerated consent. And I mean, there was a case last week in the UK, I just heard it on the news, about a woman who had gone to Turkey. People traveled abroad because of lower cost to places like Turkey, Thailand, Indonesia, to get procedures done. And she came back to the UK in a permanent vegetative state after going for rhinoplasty or nose job. And the news story was reflecting on how she'd signed all these consent forms that were in Turkish. So she hadn't even been consented properly, but because it's, and then she comes back to the NHS, and the NHS kind of deal with the aftermath. So the story was kind of how the NHS is mopping up a lot of botched surgeries that mostly women are undertaking overseas. And so there was this, I guess, the dual question of what was driving, the affective forces driving the decision to undertake the surgery, plus the absence of health literacy in this case because of a language barrier. So I don't know if that answers your question, Kathleen, but those are the kind of reflections we had. Anything else?
I suppose it's about the dialogue that ensues, that if you do not understand why somebody comes requesting something, then you cannot have a full engagement about what the possibilities might be. The problem with shame and other emotions in the consent process is that it closes off certain avenues and certain choices and certain discussions. So if somebody comes voluntary and says, I want a rhinoplasty, then that might actually limit the discussion entirely. It might be, okay, that's fine. Here's the risks even of a rhinoplasty, but there may be no more extensive discussion than that, as opposed to thinking about why is this patient coming for a rhinoplasty. It may be that there are alternative mechanisms by which there may not. The person may well value and benefit from rhinoplasty. Cosmetic surgery, I'm not saying, is some sort of illegitimate enterprise. It has particular values, but it's about people making choices in a considered way, in full possession of all the possibilities that are available to them. And I think that that's where the failure to take account of emotion closes off those discussions, closes off those possible avenues.
Okay, thank you. That was really interesting talk, and really important area if informed consent is to be meaningful. And this is more of an observation, just a reflection on my experience of being a patient. And I think negative self-conscious emotion that's relevant here is not just about potentially revealing something shameful about yourself or your own feelings of shame about a health condition. I think also there can be something, sometimes it's maybe more appropriate to call it embarrassment, but about not wanting to maintain a smooth interaction, not kind of wanting to shame the clinician. I recently had a couple of procedures, and surgical procedures, and what I wanted to ask that I actually didn't ask was, how many times have you done this? and is there anybody who died when you were doing it? And I also wanted to ask whether it was the consultant himself who was going to do my procedure or the registrar, but that felt as well like it was risking insulting the registrar by implying that I had less trust in him. So they're really difficult conversations without implying some sort of insult to the professional who you feel in that situation that you're obliged to accept their professionalism and maybe just not ask some of the difficult questions you want to ask.
I think so. Another question you might want to ask is, how old is the consultant? Performance declines after the age of 55, technically, so you might want to think about that. I suppose one of the things is about the way healthcare is constructed. So healthcare is constructed from the top down. So the systems are designed to make the organization run as efficiently as possible. It's not designed from the patient up. So it's not designed to accommodate the needs and wishes and rights of individual patients. And so when you've got this constructed environment, coming in as a patient, it's very difficult to disrupt that environment, and you don't want to disrupt that environment because Again, you've got skin in the game for one. You don't want to upset your clinician in any shape or form, because they're the person who's going to be looking after you. So there are all sorts of trade-offs in that environment. And so I think the way healthcare is constructed is inherently problematic from a patient's perspective. So that even you, who's a very knowledgeable, articulate individual, finds it difficult to vocalize certain really quite straightforward and simple things. And so you can imagine if somebody goes with something that's intimate and personal and know that they feel embarrassed about or ashamed about, or, you know, many of these things are I suppose, you know, we can talk about the language of shame and whether they imply different depths or different things in many ways, but they really preclude people from vocalizing anything. And this notion of the passive, like healthcare thrives on the docile patient. And so the environment is set up for that. And so that sort of passivity is encouraged in a way and rewarded in a way, and that you're in and out more quickly. But it is inherently problematic.
Yeah, the obligation to be a good patient. Yeah.
Thank you. Thanks, that was really interesting. And I was thinking about the way it relates to broader discussions about decision-making in healthcare as well, which I think it does. It has direct bearing on those. So the project could be broadened out to have wider applicability. But I was thinking, so when you think of it in those terms, you can also map on discussions from political philosophy in there and democratic decision-making. And it brings another lens to it, because I guess one of the intuitive responses to this is that the process of gaining consent or asking for consent should be more deliberative, right? So people are taken through a process of deliberation, where you can kind of ensure that people understand every stage of the process, rather than it just being, here's a form, sign on the dotted line. And we all know when we download apps on our smartphone, you know, how much reading goes on there. So I'm thinking, but then when it comes to sort of democratic theory, you know, then you've got debates between like libertarians and deliberative Democrats. And the libertarians are like, well, why do people have to jump through these deliberative hoops? That in some way is taking away their freedom. They should just have the, you know, if they want to make a snap judgment on something, they should be able to make it. They shouldn't have to go through this long, drawn out process of deliberation to prove to you that their decision is a rational one rather than a snap judgment. They're autonomous individuals. And I think that debate, I mean, I know where I come on that debate, but I'll not tell you here. But I think that debate, the debate between libertarians and deliberative Democrats, actually comes back to this. So while from the perspective of what you've argued today, I think you would want to go the deliberative way, because that would help you offset the role of shame. The flip side of it is then you've got people saying, well, people are autonomous individuals. They should, you know, if they want to make wrong decisions or decisions you think are wrong for them, it's up to them to do so.
And I think, I mean, this is something I've said many times before, when doctors present the information for informed consent, they present a very limited menu. I think you've used that metaphor. So it's not like you can choose anything at all and you exercise your autonomy at all. You can choose this or that.
Yeah,
maybe.
yeah.
And, you know, so it's already framed in a way that it's not really an individual making an autonomous decision and exercising any sort of freedom in that. It's constrained. It's so highly constrained in these clinical environments.
Yeah, no, thanks. I mean, I agree. It's so autonomy in healthcare is a negative right. Effectively, you get the right to refuse, but not to choose. The choice that you don't get to construct the menu. You get to choose from the menu. And you know, we might argue that that's good or bad, but I suppose there's also a public expenditure or use of public sort of resources perspectives to that as well. So people don't automatically get to use public resources in any way that they want. That needs to be constrained so that there's a fair distribution of the goods. Not that we're very good at that, I think, a lot of the time, but there is that sort of notion underpinning it. So in a publicly funded service, in a privately funded service, things might look a little bit different. And I think they're much more down the libertarian route in that sort of circumstances. But also the engagement from a legal perspective is different. You know, when you go to the NHS, you have a relationship with the NHS. When you go to a private institution, you have a relationship with the consultant, and that's a contractual relationship with the consultant rather than with the institution. So there are different ways. So you have this different sort of feel to it, or a different way of going about it. But yeah, I mean, there's so many decisions in healthcare, and they're sort of airbrushed in ways.
So on one hand, I mean, I worked on informed consent for 5 years and within a bioethics discipline. On one hand, it's an event with the way that it is understood. It's an ethical and normative understanding. On the layer which you are both are working on is the process. It's about how the social decision-making, or like medical decision-making is not just a medical, but it's also part of the social ways of any engagement with medicine, right? And now the question for me is, I mean, I think it's just a quick follow-up with Phil. If the bioethics as a discipline has moved away from paternalistic attitude, and then, okay, let's talk about respecting patient as choice and decision-making. And if we start accounting and questioning the way did they actually make the right decision, did they really think about it, would it flip towards, again, backwards? Or do you think how ideally it would happen in the context of healthcare context? I mean, especially in the clinical encounter, what ideally should be?
Yeah, so, you know, saying that people make the wrong choices and, you know, that we need to do something about that, so let's all go back to paternalism, really doesn't sound like a great option. It's the wrong choice. And it's not so much, so our argument isn't so much that people make the wrong choices. They make a particular choice given the choices that they have and the information that they have. And the question is whether there's anything missing out of that discussion. And it's not just the factual content of the engagement, it is the manner of the engagement, and it's the creating space for people to be able to articulate what it is that their concerns are, or their emotions are, or so that they can make the best choice for themselves as they see it themselves. So I'm certainly not arguing for anything else. I'm pessimistic about it. I have to say, I think our chances of creating that space is extraordinarily small within a healthcare that is under-resourced, environment under-resourced and seeking for increased efficiencies. I'd say we will end up with shrinkage of menus rather than a wider space.
Do we have any more questions? 3 more minutes.
I think we're going to let people off early.
Yeah, we can. Yeah. So thank you so much. Let's hear it.
And this brings us to the end and the close of the workshop. So I just want to take a moment to thank all our speakers and thank everyone for coming, both on Zoom and in person.